Hi class, this is Dr. Shahada, and in this video I'll be covering Chapter 8 on inpatient facilities and services. Now, I do want to make sure that you're aware your PowerPoint presentation link is right there, found in this week's module, as well as a file titled Terminology for Chapter 8, and it includes all the terms and definitions from this chapter. All right, so let's get started. Now, the term inpatient is used in relation to an overnight stay in a healthcare facility, such as a hospital, whereas outpatient refers to services provided while the patient is not lodged in a healthcare facility. Although the primary function of hospitals is to deliver inpatient acute care services, many hospitals have expanded their scope of services to include non-acute and outpatient care. So a hospital is an institution. It needs to have at least 6 beds whose primary function is to deliver patient services, diagnostic and therapeutic, for a particular or general medical condition. So hospitals actually gradually evolved from ordinary institutions of refuge for the homeless, as we've read before, alms houses and pest houses, into ultra-modern facilities. Now, I'm going to go into the topic of inpatient facilities a little deeper by switching over to our PowerPoint presentation. So let me do that now. All right, so here's the video, the PowerPoint presentation on inpatient facilities. I actually started with this funny video. It's by Jimmy Kimmel, and he was asking people on the street if they would prefer the Affordable Care Act versus Obamacare. And it's pretty funny. I think it came out in 2014. But it's just funny seeing people's responses and how confident they are with their answers when they're not aware that both terms, equate to the same policy. All right, so, remember you could click on the control button and then click on the link, and it should direct you to YouTube, to the video that was embedded here. All right, so let me get started. I'm going to start back by the intro. Okay, so we went over what an inpatient stay is, as well as a hospital. I do want to point out that a hospital must be licensed, have an organized physician staff, and provide continuous nursing services supervised by RNs. Other hospital characteristics. Well, a governing body is legally responsible for hospital conduct. We have the CEO, which is responsible for operations, medical records on each patient, pharmacy services that are supervised by a registered pharmacist, and food services to meet nutritional needs of the patients. Now, construction and operations of a hospital are governed by federal laws, state health regulations, city ordinances, joint commission standards, fire codes, and sanitation standards. All right, so I already defined what a hospital is. I'm not going to bore you and do that again. So here is the difference between an inpatient service in comparison to an outpatient service. So inpatient services are provided to patients while they have an overnight stay in a healthcare facility. Outpatient services are provided while patients are not lodged in a healthcare institution. Now, we saw this transformation of hospitals from places for the poor, like the alms houses and the pest houses, or used for quarantine purposes, to a place where the delivery of healthcare services were provided. So from the 1840s to the 1900s, hospitals underwent this drastic change from being, again, an ordinary institution of refuge to these ultra-modern facilities. All right, so now we're going to be jumping to slide number 13, where we're going to be talking about the 5 major factors that in the evolution of hospitals. All right. So the first one is primitive institutions of social welfare. So the almshouses pretty much provided food and shelter to the poor. And then we had the pest houses that were used to quarantine people with contagious diseases, such as smallpox and yellow fever. The next one is some of these almshouses actually contained infirmaries, so where ill residents were isolated, and later it became medical care institutions set apart for taking care of the sick. So we see this transition going on. Hospitals at this stage often had poor hygiene, inadequate ventilation, and care provided by untrained nurses. Advances in medical science transformed hospitals into institutions of medical practice. So we had this advanced equipment for diagnosis and treatment. Facilities and personnel training became centered in the hospital. Hospitals became more acceptable to the middle and upper classes, and hospitals were able to generate a profit. So hospital administration, organization into departments, and cost efficiency became very important. So they became these organized institutions of medical practice. Now, advanced institutions of medical training and research. So the application of medical science and technology in hospitals made it necessary for physicians to receive their training and to practice medicine in hospital settings. In affiliation with university-based medical schools, so many hospitals became centers of medical research, and we have these teaching hospitals coming up that began to emerge. And the last stage, really in this evolution of hospitals, is that hospitals became institutions of health service consolidation. Various economic and social factors have led to the downsizing of hospital capacity, but consolidation strategies, such as the formation of multi-hospital systems through mergers and acquisitions, created this diversification into non-acute services and affiliation with networks through contractual arrangements became necessary. Now, the following slides after this slide go into detail into these 5 main stages. But I'm going to jump to slide number 24, and we're going to start talking about this stage of expansion, because what happened is hospitals went through this big expansion period where they increased throughout the nation, and then they downsized. So we're going to first touch on the factors that contributed to this growth of hospitals in the U.S. So one of the main factors is advances in medical science. Then we had the development of specialized medical technology. And then advances in medical education, which transformed hospitals into institutions of medical practice. Now, the third one is the development of professional nursing, which ensured increased efficacy of treatment, and hygiene improved patient recovery. Along with the previous 3 developments that I touched on, trained nurses really transformed hospitals into places of healing. And the 4th contributor to this expansion was health insurance. It provided a vehicle enabling people to pay for hospital services. Insurance contributed to the increased demand for health services, because once people knew that they had the coverage to access health services, they're more apt to take advantage of that. Now, historically, insurance plans provided generous coverage for inpatient care. Consequently, there were few restrictions for patients and physicians to opt for more expensive hospital services. Even more important was the method of reimbursement for inpatient care. So prior to the introduction of prospective and capitated reimbursement mechanisms, there were few restrictions on what hospitals could charge. And the last contributor to this expansion in hospitals is the Hill-Burton Act. So I'm going to switch to the slide that covers this act and talk a little more about it. All right, so here we are on slide 26, number 26, that covers the topic of the Hill-Burton Act. Now, the Hill-Burton Act provided grants to states for the construction of new hospital beds. It assisted in the construction of nearly 40% of the beds in the nation's short-term general hospitals and was the greatest single factor in the increase of the nation's bed supply during the late 40s all the way through the 1960s. So the Hill-Burton program made it possible for even small, remote communities to have their own hospitals. Also, the creation of Medicare and Medicaid programs in 1965 also had a very significant impact on the increase in the number of hospital beds and the utilization as government-funded health insurance became available to a large number of elderly and poor Americans. So what this act did, it was based on a bed to population ratio. So the objective was 4.5 beds per 1,000 people. Now I'm actually going to jump back to this week's section that covers some information from the chapter because I actually have a billboard that I found where it's encouraging people to vote for the Hill-Burton Act. All right, so let me switch over now. So here it is, and it says, where's the hospital? 33 counties in North Carolina have no hospitals. So this is actually encouraging people to vote for the act. I do want to make you aware that the program stopped providing funds in 1997, but about 150 healthcare facilities nationwide are still obligated to provide free or reduced cost care. Now, the next section we have in this section, the module talks about the expansion, which I just touched on. And now we're going to talk about the downsizing, the hospital downsizing. All right, so now I'm going to go to back to the PowerPoint presentation. I'll be going to slide 29, and it's actually a table where you'll be able to see the difference between the expansion, different factors that impacted the expansion of hospitals, and different factors that impacted the downsizing of hospitals. All right, so here we go. Impact on expansion. These are the different factors that we've already touched on, we've already covered. And regarding the downsizing from the 1980s onward, so there were three main factors, as you can see. The first one were changes in reimbursement. The second one is the growth of managed care. And there's also hospital closures. So Medicare no longer paid hospitals on a cost basis, as it did during that time, that era of expansion. Under the prospective payment system, or PPS, which was also adopted by other payers, reimbursement was based on diagnosis-related groups, or DRGs. So under PPS, hospitals are paid a fixed amount per admission, according to the patient's principal diagnosis, regardless of how long the patient stays in the hospital. So to make a profit, the hospital must keep its costs below the fixed reimbursement amount, which creates an incentive to minimize the patient's length of stay. Managed care expanded rapidly during the 1990s, emphasizing inpatient utilization controls and use of alternative delivery settings. So this is where we see this increase in the use of outpatient clinics, home health, and nursing homes. Such measures have had a tremendous impact on the downsizing of individual hospitals. Many rural and urban hospitals had to close for economic reasons. Hospitals of all sizes throughout the country either closed entire wings or converted those beds for alternative uses like outpatient care, long-term care, or even rehabilitation care. So the nation's bed supply overall declined. All right, I do want to mention to make sure that you review the section on access and utilization measures. I want you to get an idea of how these different measures are calculated. You will not be calculating any of them on the exam, but just, for you to understand how these, what's involved in the measure that you get or the rate that you come up with different access measures like, the inpatient day, length of stay, average length of stay. All right, so now we are going to jump to the types of hospitals by ownership. So I'm going to go to slide number 48. All right, so here we are. We have public hospitals, private nonprofit hospitals, private for-profit, and then we have federal hospitals. So let's start with the public hospitals. So public hospitals are operated by the federal, state, and local governments. Federal hospitals serve special groups of federal beneficiaries. This includes Native Americans, military personnel, and veterans. As a general rule, federal hospitals do not serve the common public. State governments operate some of the largest mental health institutions. Local governments, such as counties and cities, operate hospitals that are typically open to the general public. These hospitals serve as an important safety net for the inner city, indigent, and disadvantaged populations. Some large public hospitals are affiliated with medical schools and offer residency programs to train physicians and other healthcare professionals. So a great example of this would be Jackson Memorial in Miami, where they are known to be a safety net hospital, where they are serving inner city, indigent, and disadvantaged populations, as well as being a teaching hospital as well. All right, so now I'm going to go through talking about the difference between private nonprofit hospitals and for-profit hospitals. So we are going to be jumping to slide number 53. All right, so when we're looking at nonprofit hospitals, they're owned by community associations or other non-government organizations. They're operated primarily for the benefit of the community, and nonprofit really means they cannot distribute profits to any individuals. They're also tax exempt. Then when we look at for-profit, we're looking at, they are owned by individuals, partnerships, or corporations. Financial returns to the owners or stockholders is an important objective, and they do pay taxes. And there are a significant number of physician-owned specialty hospitals. All right, so are nonprofit hospitals better than private? Nonprofits compete head-on with private hospitals. They have the same providers, same patients, same insurance, third-party sources for revenue. They both use same aggressive marketplace behaviors and both provide similar levels of charity and uncompensated care. Now, when it comes to the Affordable Care Act and nonprofit institutions, nonprofit hospitals must assess community health needs and implement plans to meet those needs. They are also responsible for establishing written policies on financial assistance and emergency care. There's a limit on charges according to financial assistance policy. There's a limit on billing and collection agencies. And they report on community health needs and provide annual audited financial statements to the IRS or face an excise tax. All right, now regarding community hospitals. So a community hospital is a non-federal short-stay hospital whose facilities and services are available to the general public. Its primary mission is to serve the general community. Non-community hospitals have been designated to serve only certain categories of people. For example, federal hospitals serve Native Americans, military personnel, and veterans, as I had mentioned earlier, not the general public. So that's the primary difference between a community hospital and a non-community hospital. So here is a pie graph where it's a breakdown of the U.S. community hospitals by type of ownership. So we have our private, nonprofit around 58.3%, state and local government, we're looking at around 22.1%, and then private for-profit is about 19.6%. And these rates are from 2010 from the National Center for Health Statistics. Now for the next slide. So here we're talking about general and specialty hospitals. So a general hospital includes most hospitals in the U.S. are general hospitals. They provide treatment, drugs, and surgical services for acute medical conditions. General does not mean less specialized or inferior care. Keep that in mind. Specialty hospitals is exactly what the name means. Only certain types of patients or those with specified illnesses or conditions. So traditionally, we're looking at tuberculosis, psychiatric rehabilitation, and children's hospitals. All right, now for teaching hospitals. So some major teaching hospitals are affiliated with medical schools. When there is an active collaboration between the university, its medical school, the hospital and health system, and healthcare professionals, it is known as an academic health center. So here is a table, not a table, a diagram. I'm sorry about that. And we're looking at the teaching hospital, academic medical center. And the question is, why be an academic medical center? Because it's uniquely capable of conducting basic and applied clinical research, while also providing healthcare services and offering medical education. Now, a little more on teaching hospitals. I wanted to touch on the primary difference between teaching hospitals and non-teaching hospitals. So there's really three main differences between both types of hospitals. First, teaching hospitals provide medical training to physicians, research opportunities to health service researchers, and specialized care to patients. These hospitals receive additional payments from Medicare for the costs incurred in operating training programs for medical or podiatric residents. The second major difference is the broader and more complex scope of services offered by teaching hospitals. These hospitals more frequently operate several intensive care units, possess the latest medical technologies, and attract a diverse group of physicians representing most specialties and many subspecialties. Major teaching hospitals also offer tertiary care services not generally found in other institutions. This includes burn care, trauma care. Teaching hospitals attract patients who frequently have more complicated diagnoses or are in need of complex procedures. So as a result of the greater case mix complexity of teaching hospitals, greater amounts of resources are required for treatment. Finally, many of the major teaching hospitals are located in economically depressed, older inner city areas and are generally owned by state or local governments. Consequently, these hospitals often provide larger amounts of uncompensated care than other hospitals. All right. Now I'm going to go back to this week's module just to see what other information I had listed there. But make sure to go through the rest of the PowerPoint presentation. Remember, there's a couple of other hospitals that are discussed, as well as, your patient's legal rights, informed consent, advanced directives, ethical principles. So make sure you read your chapter and go through the PowerPoint presentation. All right, so now I'm going to go back. All right, so here we are. And we've already reviewed everything pretty much listed here. Make sure to review the chapter. And if you have any questions, be sure to let me know. Take care. Bye.